Welcome to session 5 of day 2 of Rhythm Interventions Online 2023. I'm Devi Nair, and for this session, I'm delighted to welcome a fantastic panel. Dr. Rahul Doshi from Scottsdale, US, Dr. Fu Song from London, and Dr. Vivek Reddy from New York. And our focus is dual chamber leadless pacing, whether it's a paradigm shift or not. Myself and the team at St. Bernard's Heart and Vascular Center in Jonesboro, Arkansas, recorded a case recently of the dual chamber AVEIR system. And we've divided it into several segments that will allow us a lot of discussion throughout the session. However, before we start, let's take a look at the first poll and see how excited our audience is about this technology. So if you can bring that first poll up. So how excited are you about this dual chamber leadless technology? Are you not at all excited? You're thinking about it, picking up some enthusiasm? You're very excited, and you can't wait to have this access and have access to this technology. So vote now, and we'll come back and look at this poll results later. So what I'll do is I'll actually go on to presenting our case. And feel free to jump in and ask questions in between. And I'll stop in between each of the clips, and we can have a lot more discussion. So just a little bit of background on why leadless. And we all know that transvenous therapies carry its own risks. There's about 12% risk of complications attributed to pocket or leads that have been shown in the literature, whether it's surgical pocket-related complications from infection, hematoma, erosion, whatnot, or lead-related complications like fractures, insulation breaches, or any vascular issues. All of these result in a pretty bad experience for the patient, but also just the patient experience as such from a chest scar or having the visibility of knowing that they have a pacer there or restriction for their arm movement and such have led to the need for a leadless system. And today we'll be discussing the AVEIR leadless pacemaker system. And it has really three components. The first is the pacemaker capsule, which has a right atrial device and a right ventricular leadless pacing device. And we'll discuss a little bit more on both of them. Both of them come independent, loadable device with an active fixation helix design. It comes with a delivery system and a retrieval cap. The device is designed to be retrieved. And you can see both of those handles are pretty ergonomic, single operator use, kind of look the same. So you don't have to remember how to use them when you actually are in time to use a retrieval catheter. Has a delivery introducer sheath as well. And then the actual programmer, the Merlin 3650 programmer with the link module that connects to these systems. Now, looking at the device as such, the atrial device or the atrial leadless pacer, it has three components. You can see the main components as such are the docking button, which allows for not only delivery but also retrieval of the system. The helix fixation, there are two helixes there. So the outer helix, which is the inactive or electrically inactive helix that provides the main fixation or primary fixation. And then there's the recessed inner helix that's mainly for mapping, but also gives some additional fixation in the right atrium. You can see the atrial device, when you look at the measurements, it comes a little bit shorter and stubbier than the ventricular device. And the recommended site is usually the base of the right atrial appendage. The ventricular device is a little bit longer. It also has a docking and retrieval mechanism. It also has an electrically inactive active fixation helix, which is used to implant the device. But the mapping is using a tip electrode. The cathode sits at the dome of that helix and has allows for that pre-mapping capability that you'll see during the case. The helix also has these anti-rotation sutures or nose cone sutures that prevent counter-rotation of the device. You'll see the battery, which is a newer battery than its predecessor, the NanoStim, and you'll see some of the battery longevity. Also has a docking button, which is for delivery as well as retrieval. Regarding the delivery catheter, the tether comes in adjustable lengths, so you can use the same delivery catheter for both the atrial device and the ventricular device. Currently, we are using 2 delivery catheters per FDA approval, but designed to be able to take care of both the devices depending on the different tether lengths. Has a deflection handle. You can see there's a nitinol sleeve that covers the device that allows for very safe entry into the cardiac chambers. The deflection mechanism also has a brake, so you can deflect, put it in on brake, and do your angiograms. The little big blue handle is the knob that allows for delivery of the device, and the white knob towards the back end is the release mechanism. As I said, at the base of the right atrial appendage is really the recommended site for the atrial device, again, studied in the DR trial. Regarding the ventricular device, the ideal site is the lower to the mid-septal area. Not really, we stay away from the base because the device is a little bit longer, about 38 millimeters, so want to stay away from the tricuspid valve apparatus, make sure that we don't have any interaction with the valve. But again, looking for that mid and lower septal area. So coming to our case is a 72-year-old male that was admitted with syncope and shoulder fracture. He had his mild dementia. He's had COPD. He's on low-dose steroids. His echo is normal with normal valves and some moderate AS and normal ejection fraction. No other cardiac history. Sinus rhythm with intermittent sinus arrest noted on telemetry with a very low BMI, especially for Arkansas population. So when we think about treatments from a leadless pacing standpoint, I mean, this is a relatively older patient that has malignant bradycardia. And when I think about the DR system here, you know, this is a patient that has shoulder fracture. He's right-handed. Do I want to put a transvenous device and give him more shoulder restrictions? You know, it's a high-risk patient. So something to keep in mind because the patient's has got a low BMI. He's on steroids. He's got COPD. Something to keep in mind, especially as we think about recaptures of these leadless devices and the capability of the VIR system for pre-mapping. And also in this patient, the need for atrial pacing that makes, I think, the DR system probably the ideal situation here. So here we're getting vascular access. I almost always use ultrasound for my guidance. You'll see me getting 2 access here. We're still early in our I would say experience with the DR system. So I'm still using 2 access with, I actually use intracardiac echo for my atrial device and ventricular device implants in this case, but mainly because as I'm getting comfortable with the device, learning the technology, I just feel comfortable with that. And we use pre-close or per-close for pre-closure in this case. And you can see I have the ice in there, and you can see the appendage is very small, and we're getting ready to put a pigtail into the right atrial appendage and getting an angiogram. And you can see the classic rookie mistake of using a pigtail that has bores that are more distal. You know, usually you have a bigger appendage, and this doesn't matter. But in this appendage, which is really small, obviously you can't really see the angiogram better, but you can kind of get a pretty good assessment of where that appendage is with the loop. That loop almost fills the appendage completely. So very small appendage. And I really did not change the pigtail in this case, since I had great visualization with ICE of where the appendage is and the walls of the appendage really well. So we're getting angiograms in both LAO and RAO to look at just defining where the appendage is, identifying where the base of that appendage is. So we're getting ready to come in with the introducer sheath here. You can see I'll get an implant, a stiff wire into the SVC, bring the sheath up and kind of unsheath in a matter. I like to keep my sheath just at the RA IVC junction, just past the eustachian ridge. We're getting ready to load the atrial device here. You can see it comes separate. That's a little loading tool. We attach the tethers on, put the device on, and then dock the device in place. And once the device is attached to the tethers, you'll see me kind of dock it in place. And once it's docked, I'll move the protective sleeve forward, cover the helix, so it protects the helix as well as the cardiac chambers as we go in. Here we're testing the deflection mechanism. We're we're actually going through with the valve bypass tool, getting through the introducer sheath. You can see me use a large bore syringe as I'm moving in to prevent any kind of air ingress. You can see as we go up, we go under fluoroscopy. I'm exposing the atrial device. If you look on fluoroscopy, you can see I'm pulling that protective sleeve back and exposing the device, which now you can see the programmer, it is detecting the device. And once the device is awake and programmed, this is one of those devices you can actually program. You can pace while you implant if you need to, even though that's not recommended. We cover it back with the protective sleeve. And at this point, under ICE guidance, I'm slowly moving the device into the appendage here and getting a better shot of that appendage with the protective sleeve in place. And you can see the appendage is very small in this case. And we're really at the base of the appendage in both this is our RAO shot and the LAO shot. Here you can see the LAO shot. And we decided to implant in this angle since this is kind of where we ended up. So at this point, I'm actually exposing the device, pulling that protective sleeve back all the way back, exposing the device. And this gives me the opportunity to map where I'm at. And to me, this is one of the characteristics of the Avior device, having that pre-mapping capability, knowing that the tissue, the quality of the tissue that you're in contact with, and knowing probably the amount of contact you're in with. And here you can actually do a current of injury. You can get a P-wave, and you can get your impedance, and you can even get a threshold. So we're doing pre-mapping, and you can see our pre-mapping here. It's a very slight injury that we see, rapid conduction, impedance is decent. I almost always do a blood pool impedance when I expose the device. So this is definitely a good impedance for this case. And once we know we have good numbers, we're getting ready to fixate, and I'm turning the blue knob, slow cadence. It's a straight shot, so you'll see that chevron on fluoroscopy move, and we're looking for about 1.5 tons, and we'll watch that very closely on fluoroscopy to make sure we don't go past. The footprint of the helix is big, but the helix as such is not as deep. So very slow rotations. And once we have done the 1.5 tons, we'll undock the device. You can see the patient actually temporarily goes into atrial fibrillation as I'm implanting the device, and as I'm undocking, you can see it on ICE as well. And quickly, the patient actually comes back into normal rhythm. Here, we're doing a tension test, mainly to make sure we have adequate fixation. So just kind of taking the slack off of that tether and making sure that the device is fixated well, both in RAO and LAO. I'll keep a little bit of tension on the device and make sure that device is fixated. You can see that we're back in sinus rhythm. We're doing some post-fixation testing here. Again, looking at current of injury, looking at our P-waves, as well as impedance, as well as threshold. Again, we expect to see a current of injury that goes up, a P-wave that potentially could go down from your pre-mapping. You can see in this case, we have a positive deflection initially and a good injury current. Thresholds are slightly elevated, but very common with an injury current that's so wide and broad, and again, done in a long tether mode when we're doing this electrical testing. So once we do the electrical testing, we know we're ready for release. And you can see me hold on to the blue knob and pull the white knob back. And as I'm doing pulling the tether knob back, you'll see the device release, the tether comes off, and we take the system back. Again, once this device is in, we'll actually look at the device in all of its angles. You can see the device on ICE. It's really implanted at the base of the appendage. You don't really want to implant the device too deep in the appendage or in alternate locations. This is the most ideal site. Obviously, in the trial, we did look at this in a different format. Here, we'll pull the system out. What I'll do is I'll actually have the team pull up our second poll before we go back to the panel for any questions. So I'd like to pose a poll to the audience. And the question is, Do you anticipate using just the atrial leadless pacemaker as the sole device for sick-sinus syndrome patients in the future? So number one option is atrial pacemaker only for sick-sinus, or number two is you're going to go dual leadless for all patients. So go ahead and vote on this poll. We'll come back to you with the results, but let's go back to the panel if possible. So any questions about the atrial device?
Hi, Debbie. I've got a question about the flexibility of where you can place a device. I think you mentioned the recommendation is based on the appendage, but when we put transvenous leads, we sometimes come across a scarred area and we have to put in unconventional locations. Do you have any experience placing it elsewhere, and sort of what are the risks associated with that?
So I will say that my experience is very limited. I've done about 12 cases so far, and I've placed most of them in the appendage. I have had to place one at the lateral right atrial wall. Mainly, we did that after pre-mapping the appendage and going to the lateral right atrial wall. But I know both Rahul and Vivek have had a significant experience with the DR system as well. So I'll have them jump in and say a few words. But I know in the trial, there were alternate sites that were used.
Yeah,
Rahul, how about you?
Yeah, it's a great question. I think when in the trial, when we were first doing the cases, we did look at a bunch of different locations actually, and turned out it was because we were worried about getting a good electrogram, and we spent a lot of time at each location in the very beginning trying to get good recordings before we screwed in. As you saw from Devi's case, that actually is not the right approach. But one advantage of that was that we ended up putting it in multiple different locations, and we are able to, somewhat surprisingly, you can put it into the lateral right atrial wall, as Devi just pointed out. You can put it in multiple locations. Now, the one location I haven't really tried, but I want to at some point, is Bachman's bundle. As you know, there's some interest in terms of decreasing atrial dispersion of activation and perhaps repolarization. But anyway, but we've never really tried to put it there, so I can't answer that question if you're thinking about that. But in other locations, it turns out you can. Now, the real issue is not can you position it there? The question then, the real issue in terms of where to position is the communication with the ventricular device. Because if the distance is too far away, then the amount of energy required for communication will cause a bigger battery drain. So it turns out when you put it at the base of the appendage, as opposed to deeper in the appendage, that's also not perfect. But at the base of the appendage and the ventricle, that tends to be a relatively sort of good position in most situations. When you start putting lateral right atrium or even posterior right atrium, then the distance starts lengthening a little bit. The orientation can be a little bit more unstable, particularly with patient movement, and the battery drain may be a little bit higher, and you may have more loss of communication. So those are the issues to think about.
If you're okay with it, I'll move on to the ventricular device implant.
Wait, actually,
and then we
David,
can come back.
Can we just make a couple of comments about the atrial implant? Because I think that you sort of pointed it out, but I think one of the things, you know, in the clinical trial, I just wanted to make the point that I was actually surprised. I think most of us were, how safe the implant was with regards to pericardial effusion, right? There was only one effusion out of 300 cases or whatever it was that required an actual pericardiocentesis out of the first 300. And that's, 50 operators or something like that. But there was a 1.6 or 1.7% rate of dislodgement, both acutely as well as another 1.7 rate of dislodgement that happened after the procedure was over, so within the next day or whatever. So I think that one of the things we've learned, and you're pointing this out, is it's really important to pay attention to the injury current, so you know that you actually have some tension with the tissue. Pay attention to the as you're rotating. Pay attention to the impedance, because you do expect the impedance to go up. It doesn't, by the way, stay up. It comes back down very quickly in the atrium, unlike the ventricle. But by paying attention to those pieces of information, I think you can both avoid too much pressure and perforation and not enough pressure and dislodgement. So I just wanted to emphasize that point.
think I'll add a couple things to that, Vivek. I think that's exactly right. And yeah, we've put devices on the lateral wall as well. And then there's the communication issue, but you get much better numbers. But the whole business of base of the appendage, there's beautiful pictures on your ICE images, Davey. But obviously you don't see that in all patients. And quite frankly, whether it's by ICE or even angiogram, especially with the type of pigtail catheter that you were using, you may not appreciate how deep the appendage is, right? And I mean, we know this from all of our appendage work, right? Going back to the last session, where sometimes the appendage can extend far distally. So another trick that you can do with dual access is actually not using it for ICE, but actually leaving it for your pigtail. That's what we've actually started doing, is actually leaving the pigtail distal in the appendage. Almost by definition, you have to implant it proximally at the base. And that's actually worked out really well for us as far as just making sure you're there on that thicker powdered tissue. The Bachman's bundle comment is going to be completely driven by anatomy, right? Because there's a dependent on that space between the appendage and the sort of septal aspect, and as you get into the SVC. But it would be the ideal place. I mean, it's thicker, it's fibrotic, it should be a very safe place to put a device. And if we get preferential conduction into the left atrium, all the better, right? So fantastic points.
Sorry, let me just make one last point about the ICE, because I forgot to make that. But Raul's point reminded me. I think the view used, which I think is a really nice one, sort of tilt back and to the right a little bit, gives you a very nice look at the appendages, particularly as it goes in. The other view that I find sometimes useful is to put the eye sort of in the SVC. So you're looking across sort of at the appendage. You get a somewhat better look at as the device tip gets closer to the tissue. But ultimately, honestly, I think this just gives you a general idea of where it is relative to the body of the appendage. And really, I think you got to pay attention again to the impedance and the electrogram and the injury current.
Yeah, then I'll throw in one last thing. Of course, we're going to keep doing this all day, related to the contact business. The perforation business, as Vivek had mentioned, it's exactly the wrong thing to do, to reposition the device multiple times. I can say that because it was my case, and we had literally done 7 or 8 repositioning because we just didn't know the numbers. It was one of the very first cases. And so that went away when we learned that we didn't have to do that. So that's pretty tremendous. But the sleeve, right? The other thing is that you've got this very supple protective sleeve, and you can use that to assess the contact as it starts to tent, right? And so that's a very useful thing for assessing, okay, this is where the tissue wall is, go a little bit further, or as you uncover, and you'll have good contact.
Yep. Okay. So I'm going to move on to showing the ventricular device implant in the interest of time. Okay. So let's move on to the next one. So here you can say we're getting ready to load the ventricular device here. In this case, obviously, we're using a different delivery system because that's what's expected of us. But hopefully in the future, we can use the same system. In this part of the video, I'm actually focusing more on the handle, since I showed the tip on the previous video. So here I'm attaching the ventricular device. Once the device we'll misalign the tethers, get the ventricular device in. I'll come back and align the tethers with that little white knob. Once the tethers are aligned, they're in place, and I'll get it out of the little loading tool that it comes in, and then we'll dock it in place, and the blue handle gets pulled back to dock it in place. Once it's docked in place, I'll move the protective sleeve forward, cover the helix, and cover the device completely, and then lock it in place, and then deflect using the deflection handle, check the brake, make sure everything's ready to go. At this point, we're getting ready to go up with the ventricular system. We connect it to all heparinized saline bags. 2 of them are to just regular gravity, and 2 of them are pressurized. Here we're going back in again through that valve bypass tool, making sure we don't have any air ingress with a large bore syringe or just a full flush on the system. And then once we are in, The importance of, again, we have to uncover the device to now wake up the new device. So you finalize the atrial device, move on to the newer leadless pacer. So the system has to connect to the newer leadless pacer. Again, one of the differentiating features of this leadless device is that you can turn on therapies at this point. So you can actually program it to VVR pace, and you can actually pace while you implant if you need to. Hopefully you don't have to, and it's not recommended, but if you did have to and you did knock out the bundle on the way in, you could. But here we are getting ready. The device is now ready to covered back up as once we program it. And here we are programming it at a low rate, just higher output, just in case we get into any issues. We'll cover it back with the protective sleeve. Very important to make sure the helix is covered with that protective sleeve. Like Raul said, that nitinol sleeve is very safe as you transition within the cardiac chambers. Very important to cross very low in that tricuspid valve. Again, you can see on the ice as well. Normally, I don't have these ice pictures on a VR implant, but you can see we're crossing. I have a nice amount of clock rotation onto the septum. I'll do both a LAO angiogram and an RAO angiogram to make sure that I'm septally oriented. I'll make sure that that I have, again, I do very steep LAO, and I'll do very kind of a moderate LAO just to confirm I'm in good position. I always do an RAO shot to make sure I have what I call the space sign, that I'm not in that anterior interventricular groove. And once I'm in good position, I'll take the protective sleeve back, exposing the device there. And at this point, the cathode is exposed. You can actually, it's in contact, and you can now do the pre-mapping. So just like the atrial device, I almost always do pre-mapping to make sure that I'm in contact with good substrate, that I'm not in a scar location. You can see the injury current. I'll check an R wave. I'll check an impedance. And if I'm patient enough, I'll check a threshold as well. But usually the injury current and the R wave and the impedance is the minimum that I'll do with the pre-mapping. And here we're behaving, and we're actually doing threshold testing. We have good numbers. And I'll show you a snapshot of what that injury current and the numbers look like. But the idea is that you can see the AGM that's collected. It's got a great R wave, adequate impedance from the blood pool impedance, reasonable threshold, and slight positive reflection with slight ST elevation, telling me that I have contact, not too much contact. So one of the things about this system is that you don't need to push this system forward. You don't have to have the goosenecking. You just have to have contact, because this is contact and then adequate fixation with the helix. So at this point, we're slowly rotating that handle, and it's a slow cadence, 1 click per second. Again, looking for that chevron to move about 1.5 tons. Really nothing much you can see on ice, other than mainly a fluoro-driven procedure. You can actually measure your impedance as you're rotating, and you'll actually see the impedance steadily increase. And once it's done its 1.5 tons, you can see me undock the device, and I'll do a deflection test to check the stability of the device. So for me, the cadence of the rotation and the deflection tests tell me whether the device is stable post-implant. And so once we have done our deflection tests and we're ready to do some post-fixation testing, we tend to see a pretty large injury current, usually after the implant or the active fixation of the helix. Again, because it's a kind of a broad base helix, so you expect a pretty wide injury current. Your R waves tend to go down. Your impedance almost always should go up. And your threshold could be pretty high just from that the injury current. And here is a great example of how wide that injury current could be. Sometimes you can have a really high ST as well. Definite increase in the impedance, about 100 ohms. The R waves are slightly low. Threshold, surprisingly, was very good, even with this injury current, probably because of just being in a good location. And this is done actually in what we call a short tether mode. With the atrial device, it's a longer tether to allow for the device to have motion, whereas in the ventricular device, at least all of my implants have been in more of a short tether mode. And as once the testing is done, now we're ready to pair the devices. And I'll kind of move on to this next video in interest of time, and then we'll take questions. So here we're getting ready to now pair the two devices. And Vivek mentioned about the distance between the devices. And I think this is something you'll see. I've kind of paused the ice, and I'm measuring on ice how far I am. And it's about, appears to be about about 60 millimeters or so, which I try to stay under 70. 60, I think, is a reasonable number between the two docking buttons. Again, this is in 2-dimension motion. You got to take all that into consideration. But you're pairing the device, but you're also selecting or testing the eye-to-eye strength. And you can see on the programmer there that we are looking at the eye-to-eye strength and the throughput between the two devices. It does automated testing. It starts at 4. Sees what the throughput is and eye-to-eye is, and you can see I have 2 stars on the eye-to-eye and about think about 95% on the throughput, and it goes up to 6 and 5 and or 6 and 7, checks it, and after it does the analysis, it recommends what the programming needs to be for the throughput and for the strength to be. And usually I tend to, at least currently, I tend to follow those recommendations, and just at least during the immediate post-implant phase. And we'll see a dramatic difference in what the throughput and what the eye-to-eye strength is, usually after the device is released, and both the devices are independent of tethers and such, but also the next day, I've seen a dramatic difference in the eye-to-eye and throughput as well. So this is eye-to-eye testing after they're paired. The device is programmed DDD in this case. You can see occasional null markers that tells you that the eye-to-eye is interrupted occasionally. And well, this is as pairing the devices. This is while the tethers are still attached. And it does the auto assessment and tells us what signal strength we have and what throughput we have, and allows us to give us a optimized setting that we could potentially use. And in this case, we opted to select some higher throughput values or higher strength, just because it was just immediate, and we were still having some null markers that tells us that eye-to-eye was not great when the tethers were still attached. So since it was a good implant and we were at a reasonable distance and reasonable eye-to-eye, we decided to release the device and pulling take the tethers, misalign the tethers, and release the device. Here I'm doing a little wiggle maneuver just after misaligning the tethers to release the device off of the docking cap. And once it's released, the devices kind of fall into place. Here, this is a slight wiggle maneuver here to release the device. And sometimes you just have to get the device nicely coaxial for it to release appropriately. Here we're kind of orienting it in properly, and there you go. The device is now released, and we'll take the docking system back and the delivery system back out of the cardiac chambers. Once the system is out, I usually let them pair the device while I'm getting vascular closure. As I said earlier, I do pre-close both of them. You'll see we'll actually stop the ice as well and make sure we don't have any pericardial effusion. We actually have ice, so might as well get all that done now. And we'll do measurements post tether release as well in multiple orientations to make sure that we're in good approximation. We'll also do final assessments in fluoroscopy. As I said, we're looking at about being 2 device lengths away from each other. That's a kind of a quick assessment if you didn't have ice, but both in RAO, LAO, and in AP rotation. And in the meantime, we'll pair the devices. Just as the video is playing, if anybody wants to jump in and talk anything about eye-to-eye, and in the interest of time, I want to make sure that everybody gets a chance to kind of bring in some final thoughts. I'll let the video continue to play.
I was going to ask a question on the pairings. I've got no experience of implanting these, and I wonder what other factors affect the eye-to-eye apart from distance. Is it just distance? Does valve regurgitation affect it? Does it help us select the right patients? What else affects the variability of the eye-to-eye and the pairing strength?
theoretically, it's the orientation of the devices. So if you just imagine the proximal or back end of each device, if they're the closer they are, and also the directionality, if they're within a 90-degree, it's generally pretty good. Having said that, that is probably, as it turns out, less important than just the absolute distance. And that's what has turned out to be the case as we got more experience in the clinical trial.
And I'll just share really quickly the DR, the 3-month safety and efficacy endpoints that was presented and was published in the New England Journal. Again, showing 98% success in implanting both the devices, more than 95% AV synchrony noted in the trial, with 90% of the patients with free of complications and acceptable atrial electrical parameters. That was also one of the secondary efficacy endpoints. Again, the 6-month data was shown at APHRS, again showing stable electrical parameters. So I just want to make sure everybody gets a chance to make some final comments on Vivek and Rahul. You have had a lot of experience with this, and you were pioneers in this early on. So just some final comments before we end the session.
Let me ask Vivek, atrial device first or ventricular device first?
Yeah, it's a great question. I actually tend to do the ventricular device first, and then put the atrial device. I feel like I have more ability to manipulate and reposition, but honestly, I think you can go either way. One of the caveats to that is that, and I would argue, Davey, and this is a good criticism, by the way, I would argue that that device was not really on the septum. It was near the septum, but I bet the tip was on the free wall. And I think that happens quite frequently. And in fact, I think it's perfectly good with this device. In fact, I think it's one of the strengths of this device. If you can put this device in the thin right atrium, then the chance of putting it into the slightly thicker right ventricle and not having a problem is actually quite good. So I think that by paying attention again to the impedance and the injury current as you showed, you can do it very safely. And also, I emphasize this because when you use, for example, the time-based device, you really do need to be in the septum. And we spend a lot of time making sure we're not doing it into the free wall. With this one, don't waste your time doing that. That would be my recommendation. Just go to a good location, put it in, and get out, because it works really well. And then just a last quick comment, which is really to your question, the audience question of atrial device or both devices.
Can we see the poll, while you're making that comment? Can we see the poll results? It'll be interesting to see.
Yeah, right. So I just want to make that comment that there's the financial issue of one procedure versus 2 procedures. There's the patient issue of 1 procedure versus 2 procedures if you have to upgrade later. But there's a third issue, which is battery drain issue. When you put just a single device, you will have probably a 20-year battery life from that atrial device. Okay, it's pretty remarkable. You get excellent battery life. When you start putting in 2 devices, I mean, we don't know what the exact number is going to be, but I guarantee you the battery drain is going to be much, much quicker, probably sub 10 years. So there are strategies that the company is working on to mitigate even that issue. But that's something else that we have to think about that we traditionally, at least I don't traditionally think about it with pacemakers.
I mean, obviously reimbursement and the cost of these devices is going to be tremendous, right? But, is certainly a factor and would support the idea of atrial device only. But as you just mentioned, the ability for this system to be in an AAI mode with backup VVI, which is coming, is going to greatly improve the battery life, 100%.
Yep.
So I have to say that brings us to the end of the session. We're running short on time, so thank you very much to our panel, who will also join us on the next session. There's still more to come. Rio Day 2's final session will start in a few moments' time. Stay tuned.